All right, everyone, let's get settled. Today we're going to tackle a big one, acid-base disturbances. If you've ever stared at an arterial blood gas printout and felt your stomach drop, you're in the right place. We're going to break this down step by step, because once you understand the patterns, you'll never look at ABGs the same way again. And yes, I promise by the end of this, you'll be able to pick out acidosis versus alkalosis in your sleep. First things first, your body works hard to keep your pH between 7.35 and 7.45. That's the sweet spot. Too low? We call that acidosis. Too high? That's alkalosis. How does the body keep it in that range? Three main players. First, buffer systems. They work instantly like your first responders. Second, the respiratory system, which kicks in within minutes to hours by controlling carbon dioxide. And third, the renal system, which takes hours to days, but can make long-term changes by holding onto or dumping bicarbonate and hydrogen ions. Keep this in mind. The buffer system's job is to maintain about a 20-to-1 ratio of bicarbonate to carbonic acid. That ratio is what keeps your pH in line. Make sure you've got that, because every single imbalance we talk about will mess with that ratio in some way. Before we can spot a problem, let's make sure we're speaking the same language. When you look at an ABG, pH of 7.35 to 7.45 is normal. PaCO2, that's your respiratory number. 35 to 45 millimeters of mercury. Bicarbonate, your metabolic number, is 22 to 26 milliequivalents per liter. PaO2 is 80 to 100 millimeters of mercury. Oxygen saturation, 95 to 100%. So the very first thing you do, check the pH. If it's under 7.35, we're acidic. If it's over 7.45, we're alkaline. Now let's talk about what happens when the problem starts in the lungs. Hypoventilation, breathing too slow, means you're holding on to carbon dioxide. That extra CO2 combines with water to make carbonic acid. The equation shifts to the right, hydrogen ions go up, and your pH drops below 7.35. You'll see a PCO2 over 45. Hyperventilation, breathing too fast, means you're blowing off too much CO2. Less carbonic acid is made, hydrogen ions drop, and your pH climbs above 7.45. You'll see a PaCO2 under 35. Think about it like this. Too slow equals acid, too fast equals alkaline. Easy rule. Now let's move to problems that start outside the lungs. Metabolic. If hydrogen ions increase, think lactic acidosis, diabetic ketoacidosis, or certain toxins, the equation shifts to the left. Carbon dioxide goes up, and the lungs compensate by breathing faster. If hydrogen ions decrease from losing acid like with vomiting or taking in too much base, the equation shifts right, carbon dioxide gets used up, and the lungs slow down to hold on to more CO2. Metabolic acidosis means pH under 7.35 and bicarbonate under 22. Causes include high anion gap problems like diabetic ketoacidosis, lactic acidosis, renal failure, and certain toxins, or normal anion gap problems like diarrhea, ileostomy, fistulas, and carbonic anhydrase inhibitors. You've either gained fixed acids or lost bicarbonate. The buffer base drops, pH falls, and the body tries to fix it by breathing deeper and faster. Those are your Kussmaul respirations. Signs include headache, confusion, drowsiness, low blood pressure, arrhythmias, and high potassium. ABG shows low pH, low bicarb, and low or normal CO2 depending on compensation. Fix the cause. Insulin for DKA, fluids for lactic acidosis, dialysis if needed. Sodium bicarbonate is only for severe cases with pH under 7.1. Metabolic alkalosis means pH over 7.45 and bicarbonate over 26. Causes include losing acid from vomiting or NG suction, or gaining too much bicarbonate from antacids or bicarb therapy, often linked to low potassium and low chloride. Signs include dizziness, tingling, muscle cramps, tetany, and slower respirations. Potassium and calcium often drop. ABG shows high pH, high bicarb, and possibly high CO2 if compensation has started. Treatment is to stop the cause, replace potassium and chloride, and watch for arrhythmias. Respiratory acidosis means pH under 7.35 and CO2 over 45. Acute causes include pulmonary edema, aspiration, pneumothorax, sedative overdose, severe pneumonia, and ARDS. Chronic causes include COPD, obesity, hypoventilation, and neuromuscular disorders. Poor ventilation causes CO2 retention, more carbonic acid, and a drop in pH. In chronic cases, kidneys hold onto bicarbonate to help buffer. Acute signs include fast heart rate, high blood pressure, confusion, decreased level of consciousness, and high potassium. Severe cases can cause increased intracranial pressure and dangerous arrhythmias. Chronic cases may feel stable due to compensation. Management is to fix ventilation, bronchodilators, antibiotics, pulmonary therapy, low-flow oxygen for chronic CO2 retainers, and lower CO2 slowly if on a ventilator. Respiratory alkalosis means pH over 7.45 and CO2 under 35. Causes include hyperventilation from anxiety, panic, low oxygen, salicylate overdose, sepsis, or wrong vent settings. Chronic causes include liver failure and certain brain lesions. Too much CO2 lost means less carbonic acid. Kidneys will eventually excrete more bicarbonate to balance. Signs include lightheadedness, confusion, numbness, tingling, tinnitus, arrhythmias, tetany, and carpopedal spasms from low calcium. Treatment is to fix the cause, calm breathing for anxiety, correct hypoxia, treat sepsis, and adjust ventilators. Sometimes you'll have a mixed acid-base disorder, like metabolic acidosis plus respiratory acidosis in cardiac arrest. The giveaway? A normal pH, but both CO2 and bicarbonate are off. Final takeaway: always interpret ABGs with the clinical picture. Don't hang your hat on one lab value without context. Treat the cause, and most of the time, the acid-base imbalance will fix itself.